Good evening, everyone, and welcome to the webinar on the theme Critical Review of Breast Cancer South Zone ESMO 2025. It gives me great pleasure to invite our Program Director, Dr. Vijay Agarwal, Senior Consultant Medical Oncologist from Bengaluru, to give the introduction and opening remarks. Over to you, sir.
Thank you very much, and good evening, everybody. It is really nice to have you all here to debate on the updates on the recent ESMO trial. I think we've got a lot of new studies in the breast cancer space, and I think we're going to discuss most of the trials today via talks as well as excellent moderation by some of our moderators and panelists. So we'll start our first talk, which is going to be on hormone receptor positive HER2 negative breast cancer, a very important Victoria 1 trial that was presented in ESMO this year. This talk is going to be done by Dr. Dilip Harindran, who is a consultant medical oncologist at Aster Medicity, Cochin. Over to you, Dr. Dilip, for your talk.
Thank you, sir. Thank you, AstraZeneca, for this opportunity. So I'll be briefly talking about the Victoria 1 trial, which was presented at ESMO this year. Can you share my slides, please?
Yes, sir.
Yeah. Victoria 1, it was basically a trial of gedatolisib plus fulvestrant with or without palbociclib versus fulvestrant in hormone receptor positive, HER2 negative, PIK3CA wild type advanced breast cancer. So gedatolisib is a pan PI3K inhibitor which targets both the PI3K and mTOR pathway. So it is the first of its kind in this subgroup. So next slide, please. Yeah. So the study design, the cohorts included hormone receptor positive, HER2 negative advanced breast cancer who were either pre or post-menopausal women or men who had progressed on CDK4/6 inhibitor or NSAIDs plus NSAIDs with less than or equal to two lines of prior endocrine therapy in advanced breast cancer with a measurable disease, and a screening result of PIK3CA should be available, and they should not have a prior type 2 diabetes or no prior mTOR inhibitor, PIK3CA or AKT inhibitor. And the stratification factors were lung and liver mets, time to progression on immediate therapy, and based on the region. It was divided into three arms in a 1:1:1 basis, and there were 392 patients who were enrolled. Arm A was the triplet therapy with gedatolisib, palbociclib and fulvestrant. Arm B was gedatolisib plus fulvestrant, and Arm C was fulvestrant alone. And an optional crossover was allowed, more importantly, from to Arm A or Arm B at progression from Arm C. Next slide, please. And the primary endpoints were PFS, and secondary endpoints were OS, response, safety, and quality of life. Next slide, please. So coming to the results, the first co-primary endpoint was in the triplet gedatolisib triplet versus fulvestrant. The PFS was significantly in favor of the triplet therapy with 9.3 months versus 2 months in the fulvestrant arm, with the adjusted hazard ratio of 0.24, which is very significant, with a p-value of 0.001. You can see the curves which has separated very well, and it seems to be a good data. Next slide. So the second co-primary endpoint was progression-free survival in the gedatolisib doublet arm. And in this doublet arm also, the gedatolisib plus fulvestrant fared better compared to fulvestrant. That is 7.4 versus 2 months with an adjusted hazard ratio of 0.33 with a very significant p-value. Next slide, please. So key secondary endpoint again was the overall survival. The overall survival actually was 23.7 months in the triplet arm versus fulvestrant. It was 18.5 months with an adjusted hazard ratio of 0.69, and the p-value was not that significant in this. And the gedatolisib doublet arm, the median OS was not reached versus fulvestrant at 18.5 months as told previously, and the adjusted hazard ratio was 0.74, and the p-value has not yet reached significance. Maybe with a longer follow-up, the overall survival might come into picture. So at the data cutoff was 30th May of 2025. 99 patients across the arms had died. Next slide, please. So again, the other key secondary endpoint was the tumor response in patients with evaluable disease. The objective response rates was significantly better in the triplet and doublet arm when compared to the fulvestrant arm, as you can see in this table. And median duration of response was 17.5 months in the triplet arm and the 12 months in the doublet arm, and it was not reached in the fulvestrant arm, not evaluable. Next slide, please. So coming to the safety and tolerability, the triplet and the doublet arm had actually more features of stomatitis, rash, diarrhea, etc., which is actually it should be there actually because we are adding the gedatolisib and the palbociclib, but most of them were actually very well tolerable, and the grade 3 adverse events were also not many, and it was not much significant. The grade 4 adverse events are also less in any of the in both of the arms. Next slide, please. So concluding, Victoria 1 was the first study to demonstrate a statistically significant and meaningful improvement in PMS with a pan-PIK3 inhibition in patients with PIK3CA wild type, all of whom received prior CDK4/6 inhibitors. As alluded to earlier, median progression-free survival was better in both the triplet and doublet arm. The efficacy of the gedatolisib based therapy was comparable regardless of the prior CDK4/6 inhibitor used, and the adverse events associated where hyperglycemia was low actually, and as was diarrhea, but most of them were grade 1 and 2 severity, and so it's actually a tolerable molecule. And study treatment discontinuation due to treatment related adverse events was 2.3% in triplet and 3.1% in doublet arm. These study results validate the PAM pathway as a molecular driver in PIK3CA wild type disease. So gedatolisib plus fulvestrant with or without palbociclib can represent a potential new standard of care in hormone receptor positive HER2 negative PIK3CA wild type ABs advanced breast cancer whose disease progressed on or after treatment with CDK4/6 inhibitors, provided we have a longer follow-up of the overall survival also. Thank you.
Thank you very much, Dr. Dilip, for that excellent. I think it's one of those few studies that have shown good data after progression on CDK4/6 inhibitors. And I think we have another similar study by Dr. Suresh. Dr. Suresh is the consultant medical oncologist at Kaveri Hospitals in Chennai. And he's going to talk to us about another situation where we have progression on CDK4/6 inhibitors, but about more on oral SERDs and how they would benefit this group of patients. So Dr. Suresh, over to you, please.
Yes, sir. Thank you, sir. Are my slides visible?
Yes, they are.
Yes.
Yeah. So good evening, everyone. So today I'll be discussing about giredestrant, an oral selective estrogen receptor antagonist and degrader, plus everolimus in patients with ER positive, HER2 negative advanced breast cancer who are previously treated with CDK4/6 inhibitor. And this is the primary results of the phase 3 evERA breast cancer trial. So the study design, it is a global randomized open label phase 3 trial. So patients with ER positive, HER2 negative advanced breast cancer, patients are eligible if they have received 1 to 3 lines of prior therapy, and endocrine therapy should be 2 or less than 2 lines of prior therapy. So patients should have developed progressive disease or relapse with prior CDK4/6 inhibitors plus endocrine therapy, and no prior chemotherapy is allowed in advanced breast cancer setting. And patients should have measurable disease as per RECIST criteria. Patients 1:1 to either giredestrant 30 mg plus everolimus plus fulvestrant, plus everolimus 10 mg. So the standard of care endocrine therapy can be either tamoxifen or fulvestrant or exemestane. The patients were stratified according to prior treatment with fulvestrant, ESR1 mutation and according to the site of disease. Assessed PFS in ESR1 mutant population as well as in the intent to treat population. The key secondary endpoints are overall survival and overall response rate and duration of response. So this is the results of the study. We can see from the Kaplan-Meier curve that the PFS is significantly prolonged. PFS for giredestrant plus everolimus is almost 10 months versus standard of care is 5.45 months, and the hazard ratio is 0.38. So this combination led to a clinically meaningful 62% reduction in the risk of progression or death in patients with ESR1 mutant breast cancer. So if you look at the overall survival, so the data is yet to mature. So if you look at the OS in ESR1 mutant population, the median OS is not reached for giredestrant plus everolimus versus 21.03 months for standard of care endocrine therapy. Hazard ratio is 0.62, however, P is not significant. And in the intent to treat population, we can see the the overall survival for giredestrant is not 26 months for standard of care endocrine therapy. P is significant. So if you look at the PFS and interim OS in patients without ESR1 mutation, so this is for patients who do not have ESR1 mutation, we can see the PFS is 5.72 months for giredestrant versus 5.5 for standard of care plus everolimus. And if you look at the interim OS, again, it is not significant. So OS is not different between the two arms. So if you look at the adverse events, the main toxicities seen with giredestrant plus everolimus, fatigue, decreased appetite, pneumonitis, headache, rash, arthralgia. So if you compare the toxicities between giredestrant plus everolimus versus standard of care endocrine therapy plus everolimus, it is slightly higher with the giredestrant plus everolimus, but most of these toxicities are due to everolimus in both the study arms. So conclusion, the next generation oral selective estrogen receptor downregulator, which is the giredestrant, in combination with everolimus has shown statistically significant and clinically meaningful improvement in PFS in ER positive, HER2 negative advanced breast cancer. So if you look at ESR1 mutant population, the PFS is significant. It almost led to 62% reduction in the risk of progression or death. And in the intent to treat population also, the PFS is significantly better with giredestrant, 44% reduction in the risk of progression or death. And consistent benefit with giredestrant plus everolimus was seen across key subgroups. Overall response rate and duration of response benefits were observed irrespective of ESR1 mutant status. So the safety profile of giredestrant plus everolimus was manageable and consistent with the known safety profiles of individual drugs. There were no unexpected safety findings. So giredestrant plus everolimus may represent a new effective all-oral treatment option in post-CDK4/6 inhibitor setting for patients with ER positive, HER2 negative advanced breast cancer. Thank you.
Thank you very much, Dr. Suresh, for that excellent talk on the EVERA session. I think the space after CDK4/6 progression is now getting crowded, and it's good to see that we have lots of good options for our patients. Now we move on to the HER2 positive data, mainly the Destiny trials involving Enhertu, and I would like to invite Dr. Rakesh to give a talk on the update on the DB05. Dr. Rakesh is a consultant medical oncologist from the Indo-American Cancer Institute at Hyderabad. And a DB05 is one of those landmark studies evaluating the movement of Enhertu from metastatic to early breast cancer in the adjuvant setting. So over to you, Dr. Rakesh.
Hi, good evening to all. Thank you, organizers, for this opportunity. So I'm going to briefly review the data that is out there, which was recently presented. The Destiny Breast 05, whether it trumps over the data of TDM1 in the adjuvant setting. So this trial, again, it said TDXD versus TDM1 in high-risk HER2 positive primary breast cancers with residual invasive disease after neoadjuvant therapy. This is the interim analysis of Destiny Breast 05. So this is a multi-center global randomized open label phase 3 trial. As we can see, the key eligibility criteria includes those with residual disease post neoadjuvant chemotherapy. This neoadjuvant chemotherapy should have at least 16 weeks of neoadjuvant treatment, at least 9 weeks of them with trastuzumab and 9 weeks of them with taxanes. The high risk is defined as presentation prior to neoadjuvant therapy with inoperable early breast cancer, which is again clinical T4.
Sorry to interrupt you, sir. So there are a few patches on your screen. If I can request you to stop your screen share and start it again, sir.
Can you share it?
Sure, sir. We can share it from our end. Just a sec.
Sorry for that. Next slide, please. Yeah, as we was discussing, the high risk is defined as inoperable early breast cancer, which is clinical T4 or node N2, N3, or operable breast cancers with the axillary lymph node positive disease after neoadjuvant chemotherapy. Again, patients were randomized in a 1:1 fashion to either TDXD of 14 cycles of 5.4 mg per kg every 3 weekly, or TDM1, which is de facto standard with 3.6 mg per kg every 3 weekly for 14 cycles. As you can see, the stratification factors, these are the extension of disease at presentation, HER2 target therapy, whether single or dual, hormone receptor based status, and also again post NACT pathological nodal status, whether positive or negative. The primary endpoint of this trial was IDFS, invasive disease-free survival, and key other secondary endpoints include distant recurrence-free survival, overall survival, and also some amount of safety data and quality of life questionnaire. Next slide, please. So this is the primary endpoint. The study met its primary endpoint of improved IDFS. At 3 years, IDFS was 92.4% in the experimental group compared to 83.7%, an absolute delta of nearly 9%, 8.7 to be precise. A hazard ratio of 0.47, inferring a 53% reduction in risk of invasive disease recurrence or death with TDXT compared to that of the TDM1. Next slide, please. So again, it also comes with the improvement in the DFS. As we can see, the DFS was improved from 83.5% in the TDM1 to 92.3% in TDXD, a hazard ratio of 0.47, an absolute difference of 8.8% at the end of 3 years. Next slide, please. So the key secondary endpoints of distance recurrence-free survival, again, we can see a delta of nearly 8%, 93.9 at TDXD versus 86.1, which was again statistically significant. Other key endpoints of overall survival were not yet mature. However, there was numerical superiority in TDXD arm at 97.4% compared to 95.7%. Next slide, please. Coming to the treatment emergent adverse effects, we can clearly see that there was more neutropenia in the TDXD arm. There were more grade 3 neutropenia in TDXD arm. Again, there was a thrombocytopenia, higher proportion of patients with grade 3 thrombocytopenia in the TDM1 arm. Apart from that, most of the toxicities was pretty much similar. And radiation pneumonitis between the two arms were also nearly similar at around 28%. Next slide, please. So this is adverse effects of special interest of ILD, pneumonitis, and LV dysfunction. If you look at the drug-related immune or ILD, we can see that TDXD, the grade 3 toxicities are less than 1% at around 0.9%. If you combine all grade toxicities, it's about 8.5% in the TDXD arm compared to about 1.6% in the TDM1. Again, LV dysfunction pretty much similar in both the groups. Again, there is a similar distribution of any grade ILD, which was observed between sequential and concurrent radiotherapy in both the treatment arms. It is about 10.7% in the TDXD compared to that of 2.6% in the TDM1. Again, pretty much what we expect from the previously known adverse effects of this drug. Next slide, please. So these are the brief conclusions of the Destiny Breast 05. It demonstrated a statistically significant and clinically meaningful improvement in the IDFS as well as DFS. with TDXD compared to that of TDM1, especially in high-risk patients and those with residual disease post-neoadjuvant chemotherapy. The hazard ratio 0.47, inferring a 53% reduction in the risk of invasive disease recurrence or death. Again, absolute numbers 92.4% versus 83.7%. Hazard ratio 0.47 was statistically significant. IDFS benefits were consistent across all pre-specified groups, and benefit of distance recurrence-free interval with TDXD was also observed. CNS metastasis and deaths and overall survival data was numerically better with TDXD. We need to see a long-term follow-up data for their statistical significance. The overall safety profile was manageable with no new signals. Again, more than 72% of the patients could complete treatment and was comparable in both the groups. And the most important treatment-related adverse effects of ILT was reported in 9.6% in TDXD compared to about 1.5% for the TDM1. However, most of these are grade 1 and grade 2 and reversible. And fortunately, the grade 3 toxicities are only less than 1%, about 0.9%. Therefore, adjuvant TDXD could be a superior efficacy, has demonstrated superior efficacy with manageable safety profile, and could represent a potential new standard of care in this post-neoadjuvant setting with people with residual disease and high-risk initial clinical presentation. Thank you very much. Next slide.
No, thank you very much, Dr. Rakesh, for that excellent. And I'm sure Dr. T. Raja will discuss what is the relevance of this study in our practice and whether we should be waiting for overall survival data or moving our practice to HER2 in the adjuvant setting. So next we have Dr. Sai Vivek, who's a consultant medical oncologist at Aster Whitefield, Bangalore, and who's going to talk to us about the Destiny Breast 09 update. That is also a very, very important study, a study looking at the role of HER2 in the first-line metastatic setting. Over to you, Dr. Sai Vivek.
Yeah, thank you, sir, and thank you, organizers, for this opportunity. So I think for the last decade, nearly a decade, I think trastuzumab plus pertuzumab plus a taxane, as per the Cleopatra data, was the standard of care in the first-line metastatic breast cancer in patients who are HER2 positive. So now this was creating a lot of chatter in this year's ESMO, Destiny Breast 09. It was a presidential symposium this year. And let's go through a few of the slides which are of interest to us. So Destiny Breast 09 is a randomized multicentral open label phase 3 study. And the patient population was first-line HER2 positive advanced and metastatic breast cancer. And the DFI, like the Cleopatra, had to be 6 months after the neoadjuvant therapy, if at all the patient initially was a localized breast cancer and progressed to metastatic breast cancer. One prior line of endocrine therapy for adjuvant or metastatic breast cancer was permitted, and asymptomatic brain metastasis was also allowed. So there were some pre-planned stratification factors which we will be discussing in detail. They stratified patients as per de novo metastatic disease versus recurrent, whether the patients were hormone positive or hormone negative. And an interesting thing which we will see now is they also stratified patients based on PIK3CA mutation detected versus not detected. So that is something which we can take home from this presentation. So patients were randomized in a 1:1:1 fashion to trastuzumab deruxtecan plus placebo, trastuzumab deruxtecan plus pertuzumab, and trastuzumab plus pertuzumab plus a taxane. So we have the results which were presented between arm 2 and arm 3. That is trastuzumab deruxtecan plus pertuzumab versus THP. The median follow-up here is 29 months. The range is from 0 to 44 months. So nearly 3.5 years of follow-up is what was presented. The trial was started in 2021 and the cutoff was February 2025, and we have the data presented in October. So the main endpoint was PFS, and the key secondary endpoints was OS and other endpoints as seen here. So before we move on, we need to know what was the PFS of Cleopatra. We are comparing it to one regimen which stood the test of time, that was 18 months. And here we have the OS from Cleopatra at 60 months. We do not have the OS data here, so let's concentrate on the PFS. So if trastuzumab deruxtecan in this particular trial was discontinued owing to adverse events, patients could switch to trastuzumab alone plus pertuzumab. the concurrent use of endocrine therapy, which was aromatase inhibitor on tamoxifen, was allowed for those with hormone-positive disease after 6 cycles of TDXT or discontinuation of taxane. An important thing to note here is now we do use data from Patina. That's why I'm mentioning this particular point. So here again, amazing study. We have early and wide separation of curves. It's a positive study in terms of the PFS. The median PFS here for the combination of trastuzumab deruxtecan plus pertuzumab was not reached, while the median PFS for THP was 31.2 months, much better than what we saw in Cleopatra. The hazard ratio was 0.09, which suggested a 51% decrease in the hazard of progression. In the recurrent setting, so this was de novo on the left-hand side. In the recurrent setting, we have a PFS of 22.5 months versus 38.0. So de novo versus recurrent. So if you look at hormone positive versus hormone negative, again, very similar in terms of the benefit. The median PFS was 27.7 months versus 38.0 months in hormone positive and 22 versus 40.7 in hormone negative. And we know that patients with hormone positive disease could receive concurrent endocrine therapy after the first 6 cycles. So the response rates in hormone positive versus hormone negative, here we have the hormone positive on the left hand side. The response rates were 81.2% versus 77, quite similar. And in hormone negative, 89 versus 80%. The CR rates though were double in hormone positive compared to hormone negative at 7.2 versus 14.5 months with the usage of trastuzumab deruxtecan plus pertuzumab. So the PFS by PIK3CA mutation status, this is what again is quite interesting here. So in the PIK3 mutation detected subgroup, which was almost 30% of the study population, the median PFS doubled at 18.1 versus 36 months. So in patients with a PIK3 mutation, which we rarely see when we are talking about HER2 as the driver, we do not consider it in our practice. But if there is a mutation, there is much better benefit, I would say, from this initial data with the usage of trastuzumab deruxtecan versus versus THP. So in the PFS curves of PIK3CA not mutated, it's 32.7 versus 40.7 months. As we see here, the magnitude of benefit definitely is better for the PIK3CA mutated. The CR rates again for PIK3CA mutated for THP stand at only 4.1% versus 14.7% for the usage of trastuzumab deruxtecan plus pertuzumab, TDXT plus pertuzumab. Even the duration of response for PIK3CA detected versus PIK3CA not detected were quite similar at 34.8 months versus 39.2 months. One thing to note, here we do say that the safety profiles in subgroups were in line with the overall safety population. But if you look at this whole study which has been published in NEJM, there were around 18 to 20% treatment discontinuations in the trastuzumab deruxtecan arm, and the treatment was replaced to be trastuzumab in those population of patients. So to conclude, very exciting study, Destiny Breast 09. It might replace the first line treatment of THP to now TDXT plus pertuzumab. But are we going to wait for further data to come out in this particular trial? I think we will discuss that in the group discussion. So the duration of response consistently favored trastuzumab deruxtecan plus pertuzumab, and CR rates were higher with TDXT plus pertuzumab, and especially in the PIK3CA mutated population. So, and this definitely would serve as an effective first-line treatment for our MBC patients with HER2 mutation status. So thank you.
Good. Thank you, Dr. Sai Vivek, for that excellent session on the DB09. And I think next we have another important update on Enhertu, which is the DB11, looking at the use of Enhertu in the neoadjuvant setting. So really exciting times for Enhertu drug, where we've just heard the data on adjuvant, on first-line metastatic, and now we'll hear from Dr. Santosh on the use of Enhertu in the neoadjuvant setting. So Dr. Santosh is a consultant medical oncologist at the Star Hospitals, Hyderabad. And over to you, Dr. Santosh, for your update on DB11.
So thank you, organizers. Thank you, AstraZeneca, for providing me this opportunity. So can I have my slides, please? So as we know, whenever we see the spectrum of treatment in metastatic breast cancer, especially in terms of trastuzumab deruxtecan, it has ascended its lines from a metastatic setting to the third line, second line, first line in the adjuvant space. Now we are seeing data in the neoadjuvant space. So this is how a typical approval. There are little bit challenges in a metastatic versus a curative settings. We will discuss in terms of those challenges in this presentation. Next slide, please. Can I have? Yes. So this is the design. Everyone knows the major construct of this design. So what I would focus on, what are the important pertinent changes in this particular design? As we can see, the standard of care arm, what they have chosen is dose dense anthracycline followed by THP. Yes, this is a standard of care, but nowadays we are using non-anthracycline based regimen in the form of PTCH. That is one thing. The third arm, as you can see, is single agent trastuzumab deruxtecan only. What independent data safety monitoring board has observed that this regimen might not be useful and this regimen was discontinued because the response rates were found to be inferior. So independent data monitoring safety group has discontinued this. So eventually we have arm 1 and arm 2 in terms. In arm 1, that is the experimental arm, we are giving 4 cycles of trastuzumab deruxtecan followed by THP. Whenever you see at the bottom of the slide in very, very fine writing, the important things that you can notice is the monitoring for ILD is stringent. It is in a clinical trial setting, and also once in 6 weeks, they have to undergo imaging for monitoring of ILD. So that is an important point. And the stratification is based on hormone positive or hormone receptor negative, and IHC, what is the intensity, fish-based IHC or IHC 3 plus. And these were the important stratification points. And the primary endpoint is pathological complete CR, and the others are the secondary endpoint. The important point is the monitoring was stringent and one arm was discontinued, and the continuation was with anthracycline based neoadjuvant protocol, which is less favored now, although it is efficacy wise same. But we follow TCPH. How much that would change is also a question that we would discuss subsequently. Next slide, please. So you can see, as per the primary objective point or primary endpoint, the pathological response rate in the intention to treat population was 67 versus 56%, almost a magnitude of 11%, which is statistically significant. When we see to the hormone positive set, the magnitude retained to about 9%. And when it is in hormone negative, receptor negative status, the magnitude was 16%, which the drug is much more effective. As we know, hormone positive is an internal resistance feedback where there is crosstalk between hormone receptor and also HER2. So it showed statistically significant improvement in pathological complete response in intention to treat, also pre-specified stratified population of hormone receptor positive and hormone receptor negative. Next slide, please. So this is the residual cancer burden outcomes. So if we can see the residual RCB 0 and 1, if we combine, almost 81% has RCB 0 and 1. That is, the clearance of disease is very good. If we see the hormone negative CA, the clearance of disease RCB 0 and RCB 1 combined is almost to the tune of 90%, whereas in hormone receptor positivity, it is to the tune of 80%. A very good drug to control the disease. Next slide, please. So when we see the EFS is not fully matured. There was a landmark analysis that was done at the 2 years landmark, where you can see the EFS of 96 versus ESF of 93. There is a difference. We have to wait for the full maturity of the data. yes, there is a trend towards improvement of EFS, but in subsequent times when the maturing events occur, we would have the data of EFS. Based on the initial trends, there appears that it would fulfill the EFS endpoint also. Next slide. Next slide, please. So this is an important slide. Whenever we have a drug that is used in patients who have a potential of maximum cure of the disease, what is the drug causing any major harm? As we can see, I would draw your attention to ILD kind of side effects, where the grade 5 side effects were equal in TDXT arm and the comparator arm. That is 1-1 mortality, where in the other we've seen there were two mortalities in the TDXT. So having a drug-related, ILD-related mortality in a population that we are aiming at complete cure is a point we should take with a pinch of salt. Next slide, please. Next slide, please. So this is a tornado graph that is showing the overall side effect between the both arms. As we know, the dose dense AC and all will have more neutropenia and all. The nausea and all side effects are there with the TDXT arm, and it is equally balanced in the both arm. And the neutropenia and cytopenias are more predominant in the chemotherapy arm. Next slide, please. So to conclude, yes, the pathological response rate, PAT-CR rate was highest across all clinical trials of 61%, reaching much higher to 83% in hormone receptor negative and 61% in hormone receptor positive. Yes, in this type of neoadjuvant protocol, we would limit our patients to only 4 cycles of trastuzumab deruxtecan, whereas in the adjuvant strategy, they would be exposed to 1 year. Which protocol should we choose? We would have to have mature data. As of now, yes, neoadjuvant strategy gives us a potential therapeutic option where the conventional pathological response rate are increased to the tune of 10 to 12%. With this, I conclude my talk. Thank you again, organizers and AstraZeneca, for providing me this opportunity.
Thank you very much, Dr. Santosh, for that excellent session on DB11. And I think there's a lot of talks that have happened with a lot of focus on post-CDK4/6 progression, as well as the role of Enhertu in the earlier setting in HER2-positive breast cancer. Now we have an excellent panel discussion on the real-world practice of HER2-positive breast cancer, which is going to be led by Dr. T. Raja. T. Raja is well known to all of us. He's the Director of Medical Oncology Services at Apollo Hospitals based out of Chennai. Over to you, Dr. T. Raja, for moderating this session. For the panelists, we have all our previous speakers, Dr. Suresh, Dr. Dilip, Dr. Rakesh, Dr. Sai Vivek, and Dr. Santosh. We also have Dr. Arun Warrier, who's a consultant medical oncologist at Aster Medicity, and Dr. Rakesh Reddy, who's the consultant medical oncologist at Apollo Hospitals, Vizag. Over to you, Dr. T. Raja.
Yeah, Dr. Vijay, thank you so much for your kind words. And, AstraZeneca, thank you so much for putting us all together. And I would say amazing presentations. And I mean, this ESMO was really rocking, I would believe. And people call this ESMO as unlike the ASCO 25, which was not, but on the other hand, it looks like ESMO 25 is a breast ESMO, they say. So not for no reason, it is true. And I assume that my slides are visible and I'm audible. Okay.
So we can't see your slides, Dr. T. Raja.
I'm already sharing my slides.
I can't see them. I don't know if anyone else can.
Not visible, sir.
Not visible. Just let me try again. Sorry. Just hold on. Please give me a minute. I'm sorry. Okay. Let me double check on everything. It should be there now. Are you able to see, please?
Yes, sir. Now we can see it. Yeah.
Thank you. And as I said, a lot of things about breast. We will just quickly review the key trials in HER2 positive early breast cancer. Even though two very good studies on non-HER2 diseases are also discussed here. We'll come to that later. We'll quickly look at, this is the plethora of studies starting way back in NSVP B31 to the most iconic HERA trial to whatever. And then came the Neosphere, Trifina, Affinity, so on and so forth. And I have just captured all of that in one slide. And today's point of interest is in early breast cancer, HER2 space. I just want to touch upon Neosphere, Trifina, Affinity, Catherine. This is the catalog of when these trials were published, 2005 to, now up till 21, which were the current standard of practice. But these 4 trials are still setting our current clinical practice. So if I take these 3 trials, Neosphere in the neoadjuvant setting, Trifina can go with this. And Santosh talked about that, and Affinity and Catherine. So that's our early breast cancer space. If you look at the metastatic setting, Cleopatra, the standard of care until now, and then Emilia, if it were to go on, that was also touched upon by Dr. Sai Vivek spoke about that, and until the Destiny 02 in the third line setting and Destiny 03 in the second line setting really kind of rearranged the whole thought process. So that's the preliminary interlude here. So starting off, currently, what are your thoughts and how do you manage your HER2 early breast cancer patients, and what are the outcomes that you are seeing? I'll go with Dilip. Dilip started off the presentation, so I go with Dr. Dilip. Can you say what are your thoughts, particularly in the early breast cancer space, HER2 positive disease? What are the major trials that you do on a day-to-day practice, and what are the outcomes? Are you satisfied?
Yes, sir. Sir, currently we are using neoadjuvant chemotherapy with dual anti-HER2, trastuzumab plus pertuzumab in the neoadjuvant space, and then we do the definitive treatment with surgeries. That's what we usually practice nowadays. And the outcomes, when compared to the single anti-HER2 of with the trastuzumab alone, the PATSIA rates and the survival benefits are have improved. But that being said, there are some cases where the pathological responses are yet to be met. It is not as when compared to the trial settings. So there are some unmet needs in the HER2 positive breast cancer at the current state.
Okay. Dr. Suresh, is that your thought process also? So are you currently happy with your neoadjuvant and adjuvant treatment options in HER2? Do you think that you are still wanting something? What's your thoughts, Dr. Suresh?
Yes, sir. So I'm very convinced with TDXD data. I agree with Dilip, sir. But TDXD in the adjuvant setting, I'm very convinced. So I think in the neoadjuvant, I'm not yet very convinced. The trial, the Destiny 11 trial.
No, sorry. I'm just, we have not moved into those trials, Suresh.
Okay,
I'm
sir.
just asking, currently, today's practice, what is the gap that you see in the neoadjuvant, and what are your practice today, unless you are already doing TDSD in those space? But what is your current day-to-day practice, and what is your experience? What is your satisfaction level? That's the question.
Yes, sir. So in my routine practice, I commonly use TCHP regimen, sir. If the patient is T2 or node positive, I would prefer neoadjuvant therapy with the TCHP. There is also the NeoCAR trial, which omitted carboplatin and has shown non-inferior response rate. But till now, most commonly, I've used TCHP regimen in neoadjuvant settings, sir.
All right, all right. So this is the current practice, and this is the amazing lineup of the Destiny trials that have really, I would say, completely changed our outlook in the HER2 positive diseases. Everyone knows this. I mean, I don't accept the 04, which is, it established the HER2 low as a concept. Otherwise, everything is actually built upon the success of 102 to 03 to now we are hearing. So I was just trying to figure out what are the unmet need in the neoadjuvant and adjuvant setting, and people seem to be so far comfortable with what they are doing. That's fine. So now we'll move on to the studies that were discussed. DB05. How do we integrate that into our practice? So DB05 was discussed by Dr. Rakesh. Excellent discussion. Dr. Rakesh, in the adjuvant, setting, residual disease, particularly post the neoadjuvant, our current standard of care is, I would say, TDM1. That's what we are doing. And you presented the data of the IDFS, and you also showed the data of DFS, and then these were your conclusions. So 53% reduction in the risk of invasive disease recurrence or death, and 3-year IDFS rate of 92.4% versus 83.7% with the TDM1 hazard ratio of 0.47. So what's your most important takeaway, Dr. Rakesh? And what is your most important criticism of this study in your own mind?
Thank you, sir, for that question. I think it's a logical move from Destino 03 to 05. We have clearly seen that TDXD has trumped over TDM1, at least in the subsequent line setting, in the metastatic setting. And again, this is quite a high-risk patients who have a residual disease and are quite advanced at the time of diagnosis. So we do come across such patients in our practice, and probably we do have patients who have progressed on TDM1, had a early recurrence while on adjuvant treatment in the adjuvant setting, in the maintenance setting. So I think this is very heartening to see that we still can improve the outcomes beyond the neoadjuvant to targeted therapy and also beyond the maintenance with TDM1. I think the only criticism will be the amount of chemotherapy. They have stipulated the utility of 16 weeks of neoadjuvant therapy. They have stipulated the utility of taxanes, but there is no word on anthracyclines in the neoadjuvant setting. I think they have probably moved away from the anthracyclines, have concentrated only on the taxanes and utility of pertuzumab in the neoadjuvant setting. Probably these are the high-risk patients. Some of us want to give anthracyclines, so that data point probably is missing there. Apart from that, I think these are the results which are quite clearly in favor of changing the practice in day-to-day patients who have a residual disease post-neoadjuvant therapy.
Thank you, Dr. Rakesh. Dr. Arun Warrier, you are there, I believe. Can I talk to you, Dr. Arun? And,
Yes, I am.
yeah, Arun, if I can ask you, the DB05, Dr. Rakesh certainly wants to talk about anthracycline, whereas you were just listening to, the Santosh about the, and then the choice of neoadjuvant therapy. And here he has presented the IDFS and the DFS. And while Rakesh was presenting, he was also, cautioning us that the overall survival is still not, it's not yet available, of course. And then will that change our thought? That's the question he asked about this study. Arun, what are your criticism about this study? And do you think we can take this soon, tomorrow, into practice?
So I feel that one is about anthracycline. So anthracycline the debate has been there for a long time now. So all of us are because we are all speaking about early stage breast cancer, where there will be a small subset who will definitely benefit from that. But overall, if you are giving the dual HER2 blockade, that's how we used to tell that dual HER2 blockade can substitute. And here we are having more powerful drugs in our armamentarium now. So definitely anthracyclines may not be required, going by what the drugs we have with us now. So that is one thing about Andhra. And I think the second point, whether we will use TDXT upfront, the problem will be means I'm not sure, because just based on IDFS, I won't be very comfortable, because we know they have their own toxicities also. So I think at this point, I'll just wait for submission.
Dr. Vijay, if I can ask you, Dr. Vijay Agarwal.
Yes, hi, Dr. Rajan.
Vijay, until now we were whatever be the neoadjuvant therapy done, and then you end up having a residual disease. We were comfortable to use TDM1, and that's the current standard of practice. So, and obviously we realize that the TDXT is definitely a better, superior drug than TDM1. It has proven it in multiple arenas. So, what is the hesitation in taking this forward in immediate clinical practice, Dr. Vijay?
So it's you're absolutely right, Dr. T. Raja. I mean, we know that it is a superior drug. We've seen this in the metastatic setting. We've seen this with the IDFC in the adjuvant setting. Now the question is, does it eventually change overall survival? And I think that's the question: is are we using it too early, or can we use it in relapse and still get the same survival? In that sense. As with breast cancer, in these situations where we need very long follow-up to get small amount of differences in outcomes, I think it will take us a very, very long time to get that data. So one of the ways to look at it is to switch practice now. And in the absence of overall survival mature data, then to kind of go back is the situation. The other thing I feel is that probably TDXT is, in terms of toxicity, is better tolerable than TDM1 as well. And whether at least we've seen that in the metastatic setting. So whether that will also trump using TDXT in the adjuvant setting. So I am with you. I think we should try to move there. We do need regulatory approvals to kind of start using them, because there's a huge financial disadvantage otherwise. But I do feel that we should start moving towards that. So,
thank you, Dr. Vijay. That's an important point. I didn't think about whether this has a regulatory approval in the US FDA or the ESMO setting. I need to ask them, particularly in the residual adjuvant setting. So that's something that we can talk to AstraZeneca. And DB11, this was presented by Dr. Santosh. So DB11 is another exciting advancement of TDXT early into the early stage. Why wait for residual disease? Why don't we just push it straight into the neoadjuvant design? And as Santosh talked about, the design of it, the single agent TDXT kind of fell off the cliff. Then again, the comparator arm, as he pointed out, is dose dense AC followed by THP, which is currently not a very comfortable option to most of us. Most of us would go the trifina TCHP. That's what we are doing. So I agree with him what he said. But however, I think this is also putting us the concept of TDHT 4 doses, only 4 doses, followed by THP. Whether that's an important selling point or not, I'm thinking about what he said. And this is the PCR rate. We have been always sold on PCR, 67%. Probably this is the topmost number that has been achieved in the ITT population. And again, in the HR negative group, the PCR rate is 83%. And the residual cancer burden, another novel assessment tool, is, as he pointed out, is 80s and 90s. Really, eye-catching performance in this setting. Not completely mature EFS. He clearly mentioned that, but a trending superiority, and concluding that, harping on the 67.3 PCR, and as good as, even in HR positive and HR negative, 83 point mind-boggling PCR rates. So is this enough or not? Santosh, your takeaways and your criticism.
Yes, sir. So there is definitely unmet need in HER2 positive early curative setting. as we have seen, the data with adjuvant use of TDM1 also showed it did not prevent any brain metastasis. So that is one lacuna that we have where that can be reversed with TDXT. So that is one important thing. So how should we use it judicially? Should we use in the neoadjuvant way or the adjuvant way? Is there are points of each way. How do I take it is, if I choose in an adjuvant way, I am super selecting the highest risk group. There, the amount of basic patients that who are exposed to TDXT might be lesser. Those at the highest requirement might be taking the drug, but the duration is more for 1 year. That is the hinge side on this side. When I treat for all comers, yes, it might have a potential to prevent CNS metastasis. That was the problem with TDM1, but the cycles are only 4. This is a positive point here. So how much will it prevent the CNS recurrences, for which I am using this drug over TDM1, that we have to do. One thing I did not like in this trial is in patients who did not achieve pathological complete response, they have used TDM1 alone. I would have used a combination of TDM1 plus tucatinib. That is where this thing might have been modified. Possibly, I would choose an adjuvant strategy where I would super select the most highest patients who are at requirement and treat. But it's difficult. It's tough to take unless we have a maturity data. But I'm always worried if a curative patient has a mortality with ILD, then it's like very difficult for us to take in and explain. So that is one point I'm always worried of. There was 2 mortalities in the adjuvant and 1 mortality here. So this is how I discuss with my patient and take a consent call.
Those are, thank you, Dr. Santosh. I think amazing points that you raised. One is about the early use of the best bullet, only 4, and therefore am I protecting the brain adequately? That's a great point. And then again, I think what this trial could not answer properly is that even after this effort, if there is a residual disease, but on the other hand, they have a superlative number on the PAT CRs and all that. But then still, what do we do with those patients? So that's a very, very, very pertinent question. So I'm going to Rakesh Reddy. Dr. Boya is there. Dr. Boya, you are there, I suppose. Can you hear us? Dr. Rakesh Boya?
So Dr. Rakesh has not logged in as of now, sir.
Okay, fine. Okay, fine. So I will now go back to Dilip then. Dilip, what is your thought about the criticism of DB11?
So I think we need to identify the right cases for TDXT in the neoadjuvant. So maybe incorporation of scoring like a HER2-DX to identify the exact cases which would actually benefit from TDXT, especially because it's an expensive drug. Maybe a thought process which I have. Uh, Other than that, means the trial data itself is good enough data, but whom the right patients to use it is the only thing which I am concerned about.
So
Point taken.
can I ask one thing, sir? So because of the discrepancies between HR positive and HR negative, which is becoming very evident now, should we think of that also when we are, because we have a lot of anti-HER2 options at this time. So it's time to think of that.
Arun, I'm taking your point, but what exactly you want to tell? You want to use it in HR positive and HR, I mean, you want to use it in HR negative and not use it in HR positive. What is that you are taking away here?
No, it is just a thought, sir, because we never used to consider HR when selecting anti-HER2. Now with a lot of these options coming for us, so should we think of that also when you're selecting the anti-HER2?
So can I assume trying to say that in HR negative, we are even more happy to use this? Is that a good?
Because the PCR rates are like 80 plus.
I'm trying to convert your question into the answer. Yeah, your point taken. So I'm excellent discussions, but unfortunately, time. I just have to move on to the DB 09, and Sai Vivek is waiting in the wings. Dr. Sai Vivek, excellent presentation. Excellent presentation. So DB09, I think is trend setting First line has been completely ragged. Now with this, that's what I think. TDXD with pertuzumab, and as you pointed out, PFS, with irrespective of the HR status and irrespective of the PIK3CA status. That's what you pointed out. And look at the overall response rate. And so you alluded to this point that this patient in the first line setting, this represents probably another better way of treating the patient, regardless of the earlier treatment. And we'll come to that regardless little later. But then it talks about HR is doesn't matter, and PIK3CA doesn't matter. And so Sai, can you postulate why is it appear to be doing a little better with the PIK3CA? I am trying to figure out that answer. Can you tell us?
Yes, I don't think we used to use PIK3CA in HER2 positive MBC to even consider it as a major factor. It never came into our picture. So this trial had a pre-planned analysis. This wasn't a post hoc analysis, but a pre-planned analysis. If we look at the median PFS in the PIK3 positive for the THP arm is exactly similar to Cleopatra, but trastuzumab deruxtecan appears to have given them a much bigger magnitude of benefit compared to our THP. So I think we should start looking at PIK3CA probably in the metastatic cancer, just to prognosticate, or rather even to say that there's few patients where we expect THP to do well, but they progress after 10 months, 11 months in the real world scenario. Probably those are the people who are carrying that PIK3CA, and escalation to TDXT probably in the first line setting might solve the purpose for them, is how I'm looking at it now.
Yeah, I'm also intrigued because I don't know whether there was a cross correlation between the PIK3CA and whether these patients were ever exposed to hormonal therapy early on, and is this a de novo PIK3CA? And actually these thoughts occurred only when you were presenting, not that I
Yeah.
thought this. But then again, going back to the previous presenters, whether, and for example, Arun thought, how do I choose? And he wanted HR as an. I'm now thinking that whether this PIK3CA status, we need to look at this. We know very well that this can be there in de novo, irrespective of. We were always looking at this in post-progression in hormone receptor positive patients on treatment with the CDK4/6 inhibitors. But whether we can do this early on and whether this can be one of the biomarker for us to choose is the thought.
Yeah, similar thoughts, sir. But one thing that I want to ask about this trial to everyone is, I think now, apart from Cleopatra with hormone positive, HER2 positive metastatic breast cancer, Patina data is very exciting. The median PFS there is 40 months, 42 months, if I'm right. With that data sitting next to us, and here the trial allowed only, I think, tamoxifen or letrozole. Where do we put it in hormone positive MBC? I mean, triple positive MBC.
At least I can tell you that I have incorporated, I have taken patina and put this into the basket, and I am comfortably doing that
Huh.
in the in the advanced disease setting. I'm already doing that. That's what I'm doing, and I see that the patients are tolerating it very well. But
Yeah.
I'm also watching. Of course, I'm also watching the lung as frequently as possible. But maybe we will learn, and I can also listen to others' experience on incorporating patina into 0 or 9. That will be I don't know. I'm doing. But what are your thoughts, Vijay? Would you do?
No, yeah, I would incorporate the patina as well in the metastatic situation.
Watching the lung.
Yeah, and watch the lung. I mean, the data is there. The data is good. So I think it would not be right not to incorporate that in HR positive, HER2 positive disease.
Okay, now the one of the trouble that with all these trials are what if these progresses after TDXT? Dr. Suresh, I want to ask you that question. What will we do if the disease progresses after TDST?
Yes, sir. So I think maybe I would try the difficult questions here. So maybe I will whether it will be TDM1 will be useful after this. It's a question, but there are some guidelines which say we can use it, but I would prefer chemotherapy, sir. Chemotherapy with anti-HER2 backbone.
Chemotherapy. Yeah. Okay. Okay.
Yes.
Okay. So that is fine. So Vamshi has asked a question. Vamshi, what will you do if you progress after TDXT? What is your comfort level? What are you doing, Dr. Vamshi Krishna?
So, TDXD in the metastatic, you're asking, or?
In the metastatic setting right now. And
So
then
right now, I have not yet fully, going to use the TDXD for every metastatic disease. I think the Cleopatra data is still good because the second line you have an option of TDXD. So if I have a HR positive, I'm happy to just go with the Cleopatra plus palbociclib, like the
let me
study.
let me rephrase the question.
Yeah.
Suppose I have used TDXT early on, let's say in the first line,
Correct.
or if I'm adventurous and I ended up doing it on the adjuvant setting, and I have
Hmm.
not touched upon some of the other molecule. For example, I have not touched upon the pertuzumab was incompletely used in the neoadjuvant. I ended up doing adjuvant TDS. I'm just imagining. Or in first line, definitely we are using TDST straight up. Then if it progresses, do we circle back or not? Is I'm trying to ask a
So the answer is, if we are in the West, what people are doing is they're going to Dato, they're going to something else. In India, we will go back to something with a trastuzumab or a tucatinib. So probably a trastu plus tuca plus chemo is what we would go to. That's the only option that is actually left for us. Which is why I'm a little concerned with this overuse of TDXD in every line that we are now seeing. Because if we believe all of this data, you give it in neoadjuvant, you give it in adjuvant, and then, when it comes to metastatic, then you start splitting hairs. That has it been 1 year since the TDXD was given? Is it 2, 3 years? Can we give more TDXD? What's the cumulative lung? So it's a little scary.
Dr. Vamsi, we have heard this criticism whenever a blockbuster comes. We always say
Sure,
this.
sir.
What do I do if it fails? So we'll leave that large. I don't think there is a, but the points are well taken. Quickly, I have only few more minutes. Suresh, I want to come to you on your I think you presented the EVERA, Suresh. So
Yes, sir.
I'm coming back to you to EVERA. Where do we want to put this EVERA today? Quick takeaway, and then I will turn to Dilip for his Victoria.
Yes, sir. So basically, whenever we are using everolimus, in that setting, the partner for everolimus might Geridestrin might be a better partner for everolimus. So in therapy,
One
and
line,
if you're
only one
considering everolimus,
question. What is the most important toxicity with Geridestrin that we don't know as compared to fulvestrant? What did you understand?
sir, from the trial, the toxicities are mostly similar between the two. Sir. Main toxicity is because of everolimus.
Okay. Dr. Dilip, to you, and final question to Dr. Santosh. What is your Victoria? Where do you want to incorporate Victoria?
So Victoria, basically, I think post CDK4/6 inhibition only. That is this thing, and I would rather use the doublet instead of the triplet, because I think the gedatolisib, even if in the trial setting that the toxicities were less, but I think in the real world, because it's a pan PI3K inhibitor, there might be more toxicities and safety concerns. So maybe the doublet therapy after CDK4/6 inhibitors might be the way to go.
Dr. Santosh, your takeaway after this Victoria 1, where a pan PIK3C inhibitor and the Geridestrin, which is slightly better than fulvestrant and being oral also. Where do you want to fit this, Dr. Santosh?
Yes, sir. So post CDK4 setting is now what we are facing the difficulty. How do we think? So one thing that emerges is target two pathways, mTOR plus a SERT. That is how the things are going. If we see the combination of giredestrant plus everolimus showed the very good thing. So the gedatolisib, the problem is it's an IV. In a hormonal positive, we are not acclimatized giving IV, oral and all. So yes, that in real world we do everolimus plus fulvestrant kind of stuff in the second line. So that is how using a superior SERD with everolimus, this is how the pathway would emerge. It will prevent the sudden drop of the Kaplan-Meier we see in hormone positive post CDK. When we use the mTOR inhibitor, that sudden drop is prevented and there is some flattening. Yes, post CDK4/6, from now on, we should use a doublet, use an mTOR inhibitor with a strong SERD, possibly oral SERD that is available. IV, I'm not so clear with because we are having very good emerging molecules of oral SERD, chemisestrant or what are elacestrant or imlunestrant. So good oral SERDs are available, followed by possibly pan inhibitor like gedatolisib. That is how I take.
Thank you. I think spoiled for choices, I would say, and even thought-provoking is that even in first line you have 2 to 3 of these agents
Yes,
combined,
yes,
and that
combined triplet. Yes, yes,
for ragging us. But anyway,
yes.
let the toxicities become more and more clear. Then we become
Right.
wiser. So I just stop here because I think I have overshot my time. I give it back to Vijay to conduct the proceeding. Thank you so much.
Thank you very much, Dr. T. Raja, for that excellent moderation, and to all the panelists. I think it has been quite insightful in terms of evaluating where we are and how to proceed, particularly in hormone receptor positive and HER2 positive disease as well. I think my take home is that clearly the DB09 is something that one could think of incorporating into practice immediately. But for the other two, I think we need to wait for some more data or some more regulatory approvals to kind of see where we go with regards to that. But I think more excitement about the DB09. And of course, Dr. Vamshi's viewpoint as well, that Cleopatra plus Patina followed by TDXT is also a reasonable option. But thank you very much, Dr. T. Raja, for that excellent moderation. Now we come to the last part of the sessions, where we're going to talk about the ESMO updates on the triple negative breast cancers. And we know that ADCs are making huge waves in the triple negative breast cancers. So we have Dr. Arun Warrier, who's a consultant medical oncologist at Aster Medicity in Cochin, to talk to us about Tropion Breast 02. Over to you, Dr. Arun.
Thank you. So can you just put the slides from your side?
Sure, sir.
Full screen, please. Thank you. So the talk is about the Tropion Breast 02. So that is about first line dato-DXd versus chemo in patients with locally recurrent inoperable or metastatic triple-negative breast cancer for whom immunotherapy was not an option. So this is the primary research from the Tropion Breast 02 trial. Next slide. So that Tropion Breast 02, the inclusion were patients who were triple negative breast cancer who didn't receive any prior chemotherapy or targeted systemic therapy in the locally recurrent, inoperable, or metastatic setting. So basically, immunotherapy was not an option for patients who had received it in the prior treatment for triple negative as an adjuvant setting and all, and for whom there were obvious contraindications for that. And there were two arms were there. One was the dato-DXd versus the other was investigative treatment of chemotherapy, which included paclitaxel, nab-pacli, capecitabine, eribulin, or carboplatin were there. And the dual primary endpoints were OS and PFS, and the secondary endpoints as given here. Next slide. So the PFS definitely was dramatically improved, and we are having a hazard ratio of 0.57. The median PFS was almost double, 5.6 versus 10.8 months, and it was sustained. The 12 months, the difference is 45 and 25. The 18 months, it is 32 and 16.8%. Definitely, there is a clinically significant and statistically meaningful improvement in PFS, and which reduces the risk of progression by 43% yeah. Next slide. So the investigator assessment was done. I think it's almost similar. There is nothing much to add here. So the hazard ratio is 0.56 here, and the difference in PFS we are seeing is around 4.4 months. So it was both were consistent. Next slide. If you look at the overall survival, again, the DATO-DXT, the overall survival events are seen here, and here again the improvement of almost 5 months. That is whatever we got in PFS is seen here also. OS in the DATO-DXT arm was 23.7, while in the other chemo was 18.7 months. And the 12 months and the 18 months are available here, and we can see that there is there may be a bit of improvement at 18 months, that around 61 versus 51, while at 12 months it was 75 versus 67. So again, it was statistically significant and clinically meaningful improvement was there. Next slide. So the main issue with all the ADCs is about the safety. That's what we are all bothered much about. So the next few slides are about the toxicity part and the safety part. So the treatment duration is around 8.5 months. So definitely more than chemo, where it was 4.1 months. And almost 35% had exposure more than 12 months, which is very dramatic. While chemo, we know more than 12 months taking is a rarity, and hardly 10% had that. And if you look at the treatment related adverse events, we can see that the more than grade 3 events are almost similar, 33 and 29. Serious events are again same, 9 and 8%. Dose interruptions were a bit more with DATO-DXT, and we can see that associated with the discontinuation rates, maybe chemotherapy is a little higher there. So the main thing is that despite more than double the median duration of treatment with the DATO-DXT, the rates of grade 3 and serious treatment adverse events were similar, and the discontinuation rates were lower with the DATO-DXT versus the chemotherapy. Next slide. So now coming to the most common treatment-related adverse events, I think the eye is an important thing here. We are seeing newer side effects with DATO-DXT like dry eye and stomatitis. Any grade is significantly higher, and stomatitis also we are seeing more than the chemo arm. Nausea is also more. So this is again the events that we're seeing in more than 15% of the patients. So I think mainly this eye and the issues were more with DATO-DXT. While if you look at the neutropenia, anemia, and leukopenia, they're in both the arms. While there is not, but some side effect like constipation, vomiting, and decreased appetite, as expected, was seen in both, but maybe numerically higher in the DATO-DXT. So there are some emerging adverse events which we have to consider when this drug is being given compared to the 15 chemotherapy. Next slide. So again, they are looking at what is the treatment-related oral mucositis stomatitis. So in the DATO-DXT arm, events leading to dose interruption, reduction due to discontinuation was seen in 3%, 11% of patients. And the grade more than 2 events resolved to grade 1 in the majority of patients at the data cut. So what is good is that even though they have these issues, they can resolve over a period of time. And the ocular related side effect is to be watched out for. So again, in the DATO-DXT arm, even leading to dose interruption, reduction, discontinuation was 6, 4, and less than 1% only. So interruption seems to be the key thing here. And again, almost more than grade 2 coming to grade 1 was seen in 67% of the data cutoff. So with the correct interruption modification, the patients will be able to come out of this toxicity. Next slide. So to conclude, Tropion plus 02 met both the dual primary endpoints statistically significant and clinically meaningful improvement in OS and PFS. OS was hazard ratio was 0.79, while PFS it is around the 0.57. So more than 5 months improvement was seen in both these the primary endpoints. And the safety profile, as we saw, was manageable and consistent with the known profile of these drugs. So one good thing is that the patient received the treatment for a longer period of time, almost 35% receiving for more than 1 year. But the rate of grade 3 and serious adverse events was similar, and discontinuation rates were lower with dato-DXd versus the chemotherapy. So Tropion-02 support the dato-DXd as a new first-line standard of care for patients with locally recurrent inoperable or metastatic for whom immunotherapy is not an option. Thank you. That concludes the presentation.
Thank you very much, Dr. Arun, for that excellent presentation on the Tropion-Breast02. I think Dato DXD is not currently available with us, but if it does become available, I think this is good data to try to include this in our practice. But next we have Dr. Rakesh Boya, who's going to talk to us on the Accent-03, which is evaluating SASI in the first-line setting in triple-negative breast cancer, similar to the Tropion database, similar to the Tropion study. Dr. Rakesh, over to you.
Thank you, Dr. Vijay. Can somebody share the slide deck on my behalf? So I think Arun has already spoken about DATO, and this is a sphere of non-immunotherapy eligible or in patients who we cannot use immunotherapy in first-line metastatic triple-negative breast cancer. And these patients are conventionally not doing as well because of the paucity of data. And it is good that we have now two good data sets. One was already presented, the Tropion. This is the other one, Ascent-03, a randomized phase 3 study of sacituzumab govitecan, or SG as we call it in short, versus chemotherapy in patients with previously untreated metastatic triple-negative breast cancers who are unable to receive PD-L1 inhibitors. Next slide. Yeah, so this is a 1:1 randomization of 558 patients. So these are patients who are first line advanced inoperable or metastatic TNBC and not candidates for PD-L1 inhibitor, either because they are PD-L1 negative, that is CPS less than 10, where pembrolizumab has not shown benefit, or PD-L1 positive tumors, but they have already received a PD-L1 inhibitor in the curative setting, or ineligible for PD-L1 inhibitor due to a comorbidity, or those who are more than 6 months, they should have been more than 6 months since treatment in curative setting, and previously treated stable CNS metastasis were allowed, which is a very good thing. So SASI was given at 10 mg per kg, day 1 and day 8. So difference between DATO and SASI is you need day 1, day 8 schedule for SASI here, that versus chemotherapy. So even here, if you see, the chemotherapy that was allowed was paclitaxel or nab-paclitaxel and gem-carbo. So these are the three options that were allowed, whereas in the earlier trial, it was more broader. We had options of using capecitabine or eribulin or a few other options. So the endpoints is primary is PFS, OS is secondary endpoint, along with other endpoints like ORR, duration of response, and safety and QOL. So eligible patients were offered crossover to second line SG. Next slide. And among the stratification factor, whether it was de novo metastatic TNBC or recurrent within 6 to 12 months or more than 12 months from the treatment in curative settings, were the important stratification factors. Next slide. So the progression-free survival, you can see that the curves are separating early. By 2 months, you can see a visible separation between the blue and red curve, which is translating into a significant progression-free survival benefit. 6.9 months versus 9.7 months in the SG arm, which gives a hazard ratio of 0.62, a 38% reduction in the events, and with a significant p-value. The 6 months and 12 months PFS rates were 65 and 41% versus 53 and 24%. So a delta of 12, and which subsequently increased to 17% of 12 months or landmark PFS. Next slide. So even by the investigator assessment, the benefit seem is sustained. So and it is consistent with the earlier assessment. Next slide. The other one is the tumor response, and you can see that the tumor response is similar between sacituzumab and chemotherapy. And the complete response rates or partial response rates both are almost more or less similar. So 48% and 46% of overall response rates, 20 and 15% of CRs, 7 and 5% of CRs, and 41 and 40% of partial response. But significantly, the median duration of response is significantly higher. So once the patient responds, the duration of the response with SG is significantly higher. It is 12.2 versus 7.2 months. So though the objective response rate is similar, the duration of response is substantially longer with SG compared to chemotherapy. Next slide. Overall survival is not yet mature. It is at the time of latest readout. It is similar in the both the groups. The crossover is load, mind you. So, but the PFS2, you can see that after 8 months or 9 months, when the usual progressions happens, the PFS2 is subsequent. The subsequent PFS is longer in the patients who were randomized to SG arm. Probably giving us the hint that if possible, use SG in first line and rather than use it in second line and then change over to from chemotherapy to SG. So, but we will have to wait for overall survival signature to before we make a final conclusion on this. Next slide. Coming to the adverse events, most importantly, we know that neutropenia is the most important adverse events, followed by nausea, diarrhea, and fatigue. So these are something that we are used to manage neutropenia, but it is significant. The grade 3 neutropenia is 43%, so it definitely mandates PEG GCSF or GCSF support and good antiemetic prophylaxis also when you are treating with SG. The rates of discontinuation is not dissimilar compared to chemotherapy. Next slide. Okay, so to conclude, sacituzumab govitecan has statistically significant and clinically meaningful improvement in progression-free survival, and the PFS benefit is observed across the key specified groups, a 38% reduction in risk of progression or death. Overall response rate is similar, but the duration of response rate is higher. PFS2 is higher. Safety of SG is as per its known profile of causing significant neutropenia, nausea, or fatigue, but the rates of treatment discontinuation was much lower with SG compared to chemotherapy. So definitely a new standard of care for patients with previously untreated metastatic TNBC who are not candidate for PDL1 inhibitor. Thank you.
No, thank you very much, Dr. Rakesh, for that. Now we have the moderation by Dr. Vamshi, Krishna, who is the Director of Oncology Services at AIG. Over to you, Dr. Vamshi, to talk on triple negative breast cancer. And our panelists remain the same. Thank you.
Good evening, Dr. Vijay, and I'm assuming that my slides are visible. So are my slides visible, Dr. Vijay?
Yes, sir.
Yeah, you can see? Okay, fine. Right. So just to kind of clarify that we have with us now the panelists who are there. Dr. Rakesh Reddy is there, and Dr. Arun Warrior is there. Dr. Sai, are you there?
Yes, sir. I'm here.
Dr. Rakesh? Pinninti.
Yes, Dr. Vamshi. Yes.
Dr. Rakesh, are you there?
Yes, sir.
Okay. And Dr. Santosh?
Yes, sir.
Okay. And Dr. Suresh Kumar? Right. So Dr. Suresh is there? Okay, please let me know if he joins back. Right. So thank you, Dr. Vijay, and thank you, the team, for giving me this chance. We will talk on metastatic TNBC first line, and it's always good to treat cancers with some humor. So what are the options of TNBC? We have chemo, we have immuno, we have NGS and all the targeted things, the PARP inhibitors, the AR. So today, let's focus on the chemo and the immunotherapy options. So let me just start off with Dr. Rakesh Reddy. Dr. Rakesh, your usual practice in metastatic TNBC, patient comes to you, let's keep it as a simple de novo metastatic, or if patient has come, let's say 1 year after completing their adjuvant with metastasis, how do you plan your treatment?
So first, if it is de novo, then PDL1 and
Okay.
germline BRCA is something that I would definitely want to have, at least for the PDL1 to begin with. Then
Okay.
assess what is the symptom load for the patient, what is the other parameters, GCPS and all those things. And definitely PDL1 by CPS is something that I would base my initial treatment decision as well as the overall scenario of the patient, the disease load, as well as the
Fine.
performance
Fine.
status and
And those, yeah, that's why I said broad speaking, broad metastatic TNBC. Dr. Sai Vivek, anything different from your end?
Not really, sir. I think check for PDL1 and then probably chemo immuno in the first line setting if it's more than 10%. Otherwise, just chemo. But I do check for the germline BRCA1 and 2, and I like to maintain it with PARP if at all it's positive.
Perfect. I think that's what everyone is saying. Dr. Rakesh Pinninti, anything different?
Not really, sir. I think I would agree with
Perfect.
people.
So I think everybody wants to do a PDL1. So let's go back to chemotherapy. Dr. Santosh, this is the prevailing wisdom that we have all been taught up upon, that just use a sequential single agent chemo, do not use drugs used earlier. Germline BRCA, try to add a platinum. Is that a fair summation of what you do in TNBC in chemotherapy, or are you okay
Yes,
to use
sir.
a doublet? Or
Yes.
do you...
So basically, I use a singlet. I use doublet in two specific scenarios. One, if it's germline BRCA positive, I tend to
Okay.
use a carbopacly. And in a scenario where the burden of disease is higher, so I
Sure.
would use a doublet, not to increase the survival or anything, to have an early response to have a better quality of life.
Excellent. So I
These
think that's
particular scenarios, I use a doublet or else singlet.
perfect. So the reason why I just wanted to lay down as a baseline is that we are just going to start with chemo, but chemo alone does not cut it. I mean, we are all aware of the fact that it's an aggressive tumor. The PFS is probably 4, 5, 6 months, not really much more than that on a median. So that's where the whole immunotherapy and ADCs have derived. So Dr. Arun, how do you decide which IO to use in your practice? Which IO do you use, and how do you decide about the IO?
So basically, I think that data, we have to look into data, and I think that most of the patients, again, it's a preference because I think it is more of atezolizumab which I use in my metastatic breast cancer.
So you use atezolizumab in your practice?
Yeah, that is it.
Oh,
Because it
okay.
started early with that and then continued.
Okay, so atezolizumab, you're not in favor of pembro.
Pembro is there, but then the number of patients are not that great, so I tend to continue with the same immuno for my breast cancer. That's it. Giving pembro for one, atezo for the other.
Okay. Rakesh, your thoughts on this? Rakesh Reddy? Oh, sorry, I have to specify. Sorry. Rakesh Reddy or Rakesh Vizag. Either of the two ways I have to put it. Dr. Rakesh from Vizag? Rakesh is there? No. Okay. Dr. Rakesh from Hyderabad. Dr. Rakesh Miniti.
Yeah, sir. I think I would also prefer atezolizumab based upon the PDL1 being more than 10 CPS score in combination with chemotherapy and nab-pacli. Again, I kind of give doublet for most of these younger patients if they're not affording for immunotherapy.
Okay, so Rakesh, the Roche has voluntarily withdrawn its indication of atezo in breast cancer, because of the mixed data between the 130 and the 131. So you still feel that with the nab-pacli, it still works, so you want to use that?
I kind of had a positive responses in the initial phases when they had the approval, so I kind of continued to use it. I do agree that Keynote 355 has a better data now.
Okay.
I'm divided. I'm probably look for a good PAP program and use that drug in that particular setting.
Okay. Santosh, can we ask you shall we say the drugs that should not be named, the ones which have come from over the border, which seem to also work?
So, yes. So the first thing is atezo question. There is conflicting data, use of Paclitaxel, Nab-Paclitaxel, steroid, no steroid, lot of fiasco. Finally, company decided that it's not required. So I'm using pembrolizumab. That is one. And the drugs, the newer drugs that are being imported, one of the drug has some data. So in financial situations where the patient is not unable to afford for the pembro, then I would use an alternative. I used in one patient. Response of assessment is awaiting.
Okay. So this is Tori or this is Tislely? Which have you used?
Tori.
Because Tori is approved in China. Its approval is there for NMPA, and the data, I just show you that data is actually pretty good. So again, Santosh, continuing the question with you, do you feel PDL1 is the best, is still a good biomarker? I mean, does it really help you? That 10 cutoff is a bit arbitrary, as I will just show. So are you happy with PDL1 as a cutoff?
So never in breast cancer PDL1 served as a good biomarker, but this is what the data we have. Less than 10, matlab the responses are not well. So at least more than 10, I would explain the patient that this is the chances that you might have. Yes, even in more than 10, because immunotherapy is not sacrosanct, we have the data of ASCENT where you add on ADC upfront also. That data is also a very...
Yes, we will talk of ASCENT as well.
Yes.
Perfect. So, Sai Vivek, your thoughts on this? PDL1 is a good biomarker, and what do you use?
I'm not very comfortable with using only PDL1. It definitely is not the best biomarker, but in the shortage of better biomarkers, I think it serves as a guide where you can really offer immunotherapy. There are patients where it's more than one I have offered. Less than one, I'm a little sketchy about offering, but more than one, yeah. But 10 is the cutoff, I know.
Okay, fair enough. So as per approvals, it is approved only in CPS more than 10. Less than 10, the approval is not there. So that's the reason why we are having this issue. Now, logically, TNBC should work. I mean, this is supposed to be, we thought that, you know, with TILs, if the TILs go up and all these things we know, though surprisingly, TNBC is actually not a very hot tumor. So that is something that I learned recently, that it's not a very hot tumor. So we really don't know how much it works, because remember, the monotherapy with immuno has very low response rates. So as a single agent, mono doesn't work. And, you know, kind of what we have always been taught traditionally is that something that doesn't work as a single agent may not be a best drug. You have to combine it with something else. So that's why the whole chemo plus immuno has come in. Just to kind of show, this is the only data based on which the Atizo came in. This was the PDL1 IC plus, remember IC2 or 3, which translates to PDL1 more than 10 roughly. It did have a final OS that was kind of positive, though not formally tested, because it was a hierarchical design. And you know, hierarchy really played havoc with both these studies. The 131, which to me is more logical, where you actually use it with Paclitaxel, which is what many of us would be happier doing. And that again did not show any OS. In fact, it showed a detrimental OS in the Atizo arm. So based on this, you know, both of these kind of, like Santosh said, mixed results, etc., etc. This is kind of what happened. And in that, atezolizumab, nab-paclitaxel initially approved, then Roche themselves voluntarily removed it. You know, this is something as what happens when people had changed their minds. So anyway, this is about the keynote, and the keynote actually was a more relaxed trial. What they looked at is that patients should have completed treatment more than 6 months before first recurrence. Now, this is something I'll touch upon, the 6-month duration that we are seeing. Because remember, some studies have used 12 months, some have used 6 months. They use pembro with chemo. Now, in chemo, they actually had two combinations. They could use taxanes, or Pacli or nab-pacli, or they could use a doublet of gem carbo. The PDL1 cutoffs in the stratification was less than 1, more than 1. Now, again, why did they use nab-pacli, Pacli, and gem with carbo? Why not carbo in one of these? There's no way to know. Basically, the idea must be very basically that gem is maybe a weaker drug, so they added carbo. I don't know why they have done the combination of the two things. And when you looked at the primary endpoint, again, a hierarchical kind of setting, they use PFS and OS, PDL1 more than 10, more than 1, and then the intent to treat population. So complicated study a little bit. This is the PFS in PDL1, 0.65. When they had a more relaxed criterion of CPS more than 1, it did not meet significance. Again, when they looked at the more than 10 population, even here, very interestingly, no benefit was seen in the gem carbo arm. It's a subset analysis. I know it's a kind of a subset. Again, when you looked at this less than 12, more than 12 month, the benefit was seen only when it was more than 12 month or if it was de novo. So in this subgroup, again, small numbers did not show benefit. When they looked at chemo regimens, like I showed you, PDL1 CPS more than 10 and CPS more than 1, both the areas, the gem carbo did not really work. This was the updated analysis where they showed the PDL more than 10 having 0.73, more than 1, 0.86, intention to treat 0.89. And that's possibly where the whole discussion of the PDL1 came about. So, Dr. Vijay, if I have to bring you in on this point, this is what the data is. When you're looking at PDL1 CPS less than 1 to 9, both of them, the results are not great. When you look at 10 to 19 also, the result is just about coming, though it is not statistically significant. It's actually at PDL1 CPS more than 20, where you start having this nice differentiation. So Dr. Vijay, your thoughts on the keynote 355 and what should be the PDL1 cutoff that we use? Dr. Vijay? Dr. Vijay, are you there? I think Vijay is also not there. So maybe the others can take this question. Dr. Rakesh Reddy Boya, are you there?
Yeah.
Okay.
So really, it's a bit confusing as you have really put it out. So I realized it is even more confusing than I remember. And now that you point it out,
It is.
it
I
seems to be
remember
very,
it
very
today because I
confusing.
read it.
Yeah. So I think everybody agrees that PDL1 is a very inconsistent marker in breast. Even there seems to be a lot of change in. I mean, whether you do it in the which site of disease also, which metastatic site also. So it's a variegated marker in breast especially. So that apart, I think the signal starts to emerge from CPS more than or equal to 10. So that's what I have been using, and subsequent data sets that have come and the Ascent and data also, where CPS less than 10 is specifically taken into consideration. Probably we are given to understand that from the Western powers that CPS is the way to go. But I think if pushed and if the patient doesn't have any access to the ADCs, like in most of our scenarios, I have used in PDL1 of 5 and such expressions also, which reasonable benefit. It's not that I have limited, and these are the drugs that you mentioned and that must not be named. So I have used specifically toripalimab in this setting also and had benefit in that particular setting. So I mean, to make the matter simple, yes, there is a cutoff that can be used, but you can pay little fast and loose with it is what I mean, probably the wisdom says.
Fair enough. Santosh, your thoughts on this? I mean, I get Rakesh, it's a bad disease. So, sometimes you tend to go a bit elastic. So are you okay with that? I mean, if it's a high PDL1, all of us are very happy.
Yes. So I think that's the main point, sir. We are very desperate to do something more for the patient when the disease biology is bad. That is all our thought process. Suppose even if in more than 1%, if one patient responds, this could be our patient. That is what our thought process goes. So always I abide by what the data shows. As we can see, less than 10%, not very significant. More than 10%, higher the better. That's what I take. Yes.
So I think that's the thing. If it is good, it is high, you're very happy. Dr. Vijay, your thoughts on this?
Sorry, you're asking me a question when I slipped out.
No, that's fine. It's just the same
When
thing.
you look at your chart itself and you start looking at moving from CPS 20 to 10 and then 1 to 9 to less than 1, I mean, we shouldn't presume that immunotherapy is a wonder drug in triple negative breast cancer. The benefit, though, is there. It is more driven by the higher PDL1 rather than the lower PDL1 score. So if you look at your PDL1 more than 20%, okay, you have 5.4 going up to 9.2. And as we keep moving to the left, lesser the score, the benefit keeps narrowing down. Clearly, those who benefit tend to have some amount of durable response. But I think less than 10, I think we have to be very careful that we don't overcommit to the patient. that it is really beneficial because the cost is quite significant in this group of patients. And it is not that to begin with, you don't have very good options. We do have, if BRCA is positive, we do have PARP inhibitors. And now with ADCs coming up, those are again reasonable options as well for those group of patients. So I feel that instead of trying to push immunotherapy in the PD-L1 less than 10, I think we do need to evaluate other options rather than trying to do immunotherapy. Unless
Absolutely.
TMB is high. Of course, if TMB is more than 10, then that's a different matter.
Sure. So again, this is where the complications happen with the early recurrences. Patients who are recur early. No, this was not included in the study. What about 6 to 12 months? Would you use a gem carbo? Would you still use a taxane? Again, the data is not great for taxanes. Will you add carboplatin everywhere? If it is not a BRCA, we don't know the answer. Probably at this point, really no. I think one thing we will all decide, if we get a PDL1 of 90, all of us are happy. Anything less than 20, 30, we always wonder, is it really going to work well? The big question, almost a lot of our patients are now going into neoadjuvant IO. What do you do if neoadjuvant IO has been used? So, Dr. Rakesh Pinninti, your thought on this. We are pushing now for neoadjuvant IO with the PATCR data. What happens, say, 2 years down the line if you have already used it?
We will probably re-challenge it if the disease-free interval is at least 6 months. That's what the trial was saying, right?
Okay, 12 months. This used the neoadjuvant therapy. They did not specify a neoadjuvant IO could be used. So again, that brings it's important because the ADC studies are allowing neoadjuvant IO. But this study did not allow because by then you did not have the neoadjuvant IO data. So that's why I was asking. We don't know the answer actually, to be very honest. Anyone for low dose IO in breast cancer? I think after especially Atul's paper this time, anyone for low dose IO? Dr. Santosh, I can see only your face. You're going back home. So any thoughts on low dose IO?
Yes, I think in principle, it has proven beyond doubt that low dose IO in breast cancer works. Yes, I'll extrapolate the data even in the metastatic setting.
Okay, so can I be a little provocative and ask you in the neoadjuvant, you don't need for using Pembro, you don't need a PDL1, but here you need a PDL1. You're saying you're not extrapolating that, but you're exploiting low dose to here. Okay, fine.
The strategy of low dose is proven across different indications, so for which in principle I'm agreeing and I'm comfortable.
Fair enough. I personally am not very comfortable with it for different reasons. I don't want to get into too much trouble, so I generally don't give it. So that's fine, to each his own. Right. So what if HER2 is low and in BRCA mutant? So Dr. Vijay, BRCA mutant, how do you integrate it? Would you give IO plus chemo followed by IO plus olaparib?
No, I would just give olaparib.
Oh, you wouldn't use IO at all. Excellent.
No.
That's a good way of doing it. Dr. Santosh.
Sir, what I would do is in this scenario, hit with all agents. I would use chemo plus IO with a platinum followed by olaparib maintenance. So that is what I do.
Dr. Arun?
I think in the BRCA mutant case, the IO I won't give.
Okay. You won't give IO if it is BRCA mutant. Okay.
No.
Dr. Rakesh Pinninti? There's no answer. No trial has addressed this, by the way. I'm just throwing out the question for knowing what people do.
I would probably do a sequential thing, sir.
Okay. You would do chemo plus IO followed by olaparib alone or olaparib plus IO?
Chemo plus IO at progressive disease, go for olaparib.
Okay. So you would go strictly by the Olympiad data. Okay, fine. The Olympia was OS negative, but fine. I take the point. Very good. So this is how we are confusing the issues. Remember, there was a study with durvalumab paclitaxel, and that was a negative trial. There was a study called Begonia, again looking at durvalumab with TNBC, again a negative study. You had a study of Tori. This is what I was telling. And here, they used a PDL1 of the Torchlight study, which was CPS more than 1. And they had around a 2:1 kind of randomization. The PFS was actually 8.4, and the median OS is among the highest, 32 versus 19. So it's the highest compared to Keynote and IM Passion, with a hazard ratio of 0.62, which is better than anything everybody else has shown. So, if I am asked to give this per data, at least this looks very interesting. It is approved in China. Remember, the trial was only in Chinese patients. It's approved for NMPA. So if you believe that we are very different from the Chinese and this drug would not work, you can avoid it. It is not approved in India, so you're good to go by approvals. It is not approved by EU and or the FDA, so you're good to go. But it's very interesting to look at this data and then see the amount of benefit that they're getting. So overall, when I look at IO plus chemo in first line metastatic TNBC, the impact doesn't seem as good as you hope. As Vijay said, the hype is more limited to PDL1 positive. Remember that only constitutes 40% of population. It does not include a lot of patients, and it's limited to first line. So if you have not used it in first line, using it down the line, even if PDL1 is high, we really don't know if it will work. So that's my takeaway of the first line. So just thought I would add this Ascent 04. It is not presented today, but this is sacituzumab plus pembrolizumab in PDL1 positive. It's an interesting trial because it's a chemo-free regimen. There is no chemotherapy. They compared it to the standard of care chemo plus pembro. And when they have done this, remember only around 40% have PDL1 positive. They took that PDL1 positive more than 6 months again, not within 6 months. Saki plus pembro versus chemo plus pembro, PFS is better by around 4 months. 11 months, you're getting close to 1 year median PFS, which is very good. And again, when you looked at patients who took neoadjuvant IO, this is the one study which has used around 9 patients. Patients are less, 5% odd. But here, in this group, it didn't work, but otherwise it worked. So I'm not sure you can say anything out of this, but that's one of the interpretations of this study, that they could demonstrate an improvement, and even in those patients who are already used. So this could be potentially a new first-line SOC. So quickly, Dr. Rakesh Boya, your thought on this study. You think it is something we can consider, Ascent 04? Dr. Rakesh Reddy?
Yeah, sorry, I lost you while traveling. But yeah,
No issue.
they're definitely interesting. Definitely interesting. Chemo-free regimen, but way more expensive. So yeah, I
Yeah.
would like to see the
Okay.
data when it
No,
arrives.
I
Yeah.
agree. Once you talk of Saki and Dato, they're just expensive, not available. So in fact, that was the major reason I thought we would cover the early part of it rather than just go to this part, which is PDL1 negative. So what do we traditionally do nowadays? I think all the panelists said that, you're a bit elastic with regard to the level of PDL1 and kind of comfortable, even if you have a PDL1 less than 10, maybe 5 to 8 to 9. That's just step values at the end of the day. So people are using. So personally, if I have something between 1 to 10, I'm actually okay to even use toripalimab with the data that is available that seems to show it works. What about IO ineligible? So Dr. Rakesh Pinninti, your thought, what is IO ineligible? This is the term used in both the studies presented today. What's an IO ineligible drug patient according to you? Rakesh.
Probably the autoimmune diseases and had early
Okay.
progressive disease post IO utility in the adjuvant phase.
Okay. Dr. Sai, your thought on what's
Yeah,
ineligible? At least as
I agree with both, sir. I think already used progressed within 6 months of adjuvant, or
okay.
probably some medical comorbidity preventing us from using it.
Okay. Dr. Santosh?
Sir, it also includes those who have less than 10%, not eligible for approval. So they have used 1 to 10 also in this IO ineligible, both autoimmune and also less than 10%.
Fantastic. The reason why I asked this specifically is very, very funny to me. When I saw the headlines in both these studies, I thought like the first two people that it's all means those who are IO ineligible. I thought how many patients are there like that? But then both the trials actually have included IO ineligibility as those who are PDL1 less than 10. And that, when you look at this paper, the sacituzumab govitecan, it actually 99% of patients were PDL1 negative, which was less than 10. So, though you added all these people who had prior IO ineligible, majority were those who were less than 10 PDL1. So, just to keep it as mind that when they say IO ineligible, it's not what we assume as an IO ineligibility. Patients are still fit enough to take a lot of treatment, but it's just this. So, this was presented the Ascent 03 sacituzumab single agent versus chemotherapy single agent. Again, for some reason, this fondness of Pacli or Nab-Pacli. On the other side, you would use Gem-Carbo. And interestingly, crossover was allowed. That is very important in this study. They allowed crossover and they also allowed stable CNS metastasis. PFS advantage is there, but remember the other study I showed you with Saki plus Pembro, it was 11.2. So, if you are adding, you might as well add both, is the way I look at it. This showed a PFS advantage with reasonable tumor responses and duration of response. PFS2 slightly better, not by a huge amount. OS is immature. So Saki is a good option where you cannot use immuno. But remember the earlier study I showed you that used both combinations. So that's what it is. Similar to this is what I was talking about, where the PDL1 negative is 99% in both the arms. So, take it however you want. This is the Dato DXD. Again, the same questions asked and the same way you answered it. And they also looked at those negative, who IO ineligible, basically those who were not having, and I could not find the breakup of this because it was just a presentation, not the final paper. Here again, you're having a PFS HR of 0.7 with a median PFS of 10.8, 5-month difference. This did show a difference in the OS. So again, 0.79, skirting close to your margins, but it was significant positive. So they said that it is a new first-line standard of care. So let me ask Dr. Vijay. Vijay, interesting data, expensive, has its own set of complications. Where do you see ourselves 2 years from now? Getting PDX, we are going to get some variant of this Dato and some variant of Saki into Indian markets. Would you be happy to use it there?
SASI is going to be launched soon. But all of them, I've got about 4 or 5 patients who have treated with SASI so far.
Oh, okay.
The earlier we use it, the better response we get. I think my initial experiences were not great because we were like the last line of treatment. But I think now as we get more experience with it, I think we're getting some benefit from it. But having said that, I think the future in 2 years from time, I think we will all be talking about ADCs in the first line, whether it is HER2 positive or triple negative. I think certainly in breast cancer, ADC would be the way to go. And I think we will only be debating which ADC use and how to sequence ADCs rather than chemotherapy.
Excellent. I agree with you. So these are the new kids on the block. We are having HER2 lows, which will come into some picture. We have ADCs. We are getting Notch inhibitors, PIK3 inhibitors, mTOR inhibitors, AR inhibitors are out. So I think the whole IO that we are so passionately chasing now, in 2 years' time, like Dr. Vijay says, we will talk about in the past tense. So I think that's where we are going. So I think I'll stop here because it's half an hour and I think I've covered a lot of what I wanted to cover. So thank you, everyone, and over to the organizers.
Thank you very much, Dr. Vamshi, for that excellent moderation. I think this has really been a really impactful evening. I think one of the best evenings I have spent listening to the ESMO updates. In fact, it was the breast ESMO update this year, really. Lots of interesting data, lots of food for thought, lots of way to kind of evaluate our own practices, both in HER2 positive as well as triple negative breast cancers. And I think we still need to watch the space for more things coming up. So I would like to thank each and everyone for contributing this evening, and over to the organizers for the last words.
Thank you so much, sir. We would like to thank our program directors, speakers, and moderators for joining in for today's webinar.